Hello and welcome to our live chat this week. And I am so excited because we are going to talk about money, honey. Okay, well, not actual money, but how to get it. Optimal reimbursement is what all medical coding and billing professionals should seek. What that means is you are obtaining the maximum amount of money earned by your providers for whom you are reporting. Okay, doesn't that make sense? Um, you know, when you work, if you're being paid by the hour, for example, and you work 10 hours, you expect to be paid for 10 hours, right? Not 8 hours. And what's interesting is more often than not, a lot of physicians, not so much hospitals, but some hospitals, but physician offices undercode. So they're only getting $8 out of $10 that they earned and they're entitled to legally, which is one of the reasons why it's so important that we know this aspect of this job. Very, very important. And if any of you have physicians to whom you can whisper in their ear, this is one of the reasons why we always want certified, nationally certified coders and billers to be working in a practice, whether it's a one physician office or a 900-bed hospital. Now, yes, I understand we are talking hospitals here, but this is fully rounded, okay? No matter whom you are reporting, you got to know what's right and do what's right with confidence that it's legal, ethical, and correct. Because all of those things add up to accurate. All right, so enough of that. Let's talk about IPPS versus OPPS. Man, we in healthcare do love our abbreviations. Okay, but this is easy, right? Because the PPS means the same thing, prospective payment system. And the I is for inpatient and the O is for outpatient. Note, OPPS is for outpatient hospital, not outpatient physician's office. I know. Why do they have to use the same word? We don't know. Okay, but let's talk about IPPS is categorized by DRGs, diagnosis related groups. And this is a payment, it's part of episodic care. Okay, and what that means is you tell us what's wrong with the patient. You tell us the diagnosis, and we already know, based on the standard of care, what you are going to do. So there's no reason to itemize every cotton swab and every Band-Aid. We already know. So we're going to put it all into a little bundle and just that's episodic care payments. DRGs, diagnosis related groups, is the same thing, is part of episodic care. But it's really complicated. Okay, so basically, what it says is you tell us the diagnosis of why this patient was admitted, but then you also have to tell us secondary diagnoses because we already know that um, a, a, a fractured leg, okay, say a fractured tibia, the amount of resources and the care provided to a patient with a fractured tibia is going to be different than a patient with a fractured tibia who also has type 2 diabetes, right? So that is what diagnosis related groups are, is it's taking everything into account. It's taking comorbidities, complications, the whole bundle, because healthcare is complex and you cannot fit every patient into one little slot. And that's why, for the most part, you need computer software to determine the accurate DRG as opposed to doing it by hand. But basically, this is what you need to know is what is it? What is it? Is diagnosis related groups. It is the only way that Medicare pays hospitals for inpatient services to their beneficiaries. Okay, DRGs is the way to determine how much a hospital will be paid for services provided to a Medicare beneficiary when that patient has been admitted as an inpatient. Okay, not the ambulatory care center, not the emergency department, inpatient. Okay, all right. Now, outpatient, as we said, this is hospital outpatient, not doctor's office outpatient. Okay. So it is the rate of reimbursement. Now, when you learn CPT and reimbursement for outpatient, right, you learned about the schedule that identifies every CPT code and how much each particular third-party payer is going to reimburse for that, right? Okay, so this is again Medicare beneficiaries, hospital outpatient, how they're going to pay. It's not DRGs, but it is a predetermined rate of reimbursement. Now, there's a whole formula involved in this as well, depending upon where the hospital is, if it's a rural hospital. Don't worry about that for right now. Okay? All right. So let's now review the participants in this whole healthcare mishmash. Okay? We have three entities, three bodies, three participants in every healthcare encounter. Okay. Number one is the physician or the healthcare provider. So if we're talking about a hospital, this is the physician and the healthcare provider, because the hospital is considered a provider and the physician is a provider. Okay. And then we have the patient, the person who is looking for services, requires services based on medical necessity. And then we have the insurance carrier. That's a mistake, because we call them third-party payers. Why? Because Medicare, Medicaid, TriCare, workers' comp, they are not technically insurance carriers. Okay. But this is the third-party payer. Okay. So we have the person or the entity, the group that is providing care. We have the patient to whom care is being provided. And then we have a separate third-party payer. That's why it's called the third-party payer. See, 1, 2, 3. The third-party payer who is not there, is not giving any services, is not getting any services, but they're paying for the services. And now you know how to explain third-party payer. Yay! In case you didn't know before, but you might have known before. I don't know. Did you know? Okay. All right. Now we're going to talk quickly about the different types of health insurance, because the type of insurance is necessary for you to determine how to handle what is being covered, how things maybe need to be coded, specifically categorized, and how your provider for whom you are coding obtains reimbursement. Okay, so an HMO basically is a closed network, or a network of healthcare providers, okay, that have signed on and said, I want to be a part of your network. I will accept you. And that's what they do is assignment is they're saying whatever you agree to pay me for each CPT code, each procedure code, I accept. Because in exchange, you're going to send me a whole bunch of patients. That's basically what it is. Okay. Now, from the patient's point of view, if you go to a provider who is not part of the network, you're paying out of pocket. Okay. Also, an HMO, health maintenance organization, uses what is known as a primary care physician, PCP, also known as a gatekeeper, because as we have discussed so many times, for goodness sake, how are we ever going to get through this world without having 7 different names for the same exact thing? Again, they didn't invite me to the meeting. Okay, so the gatekeeper, and the reason they're called the gatekeeper is because they guard the gate to all the rest of the care options, specialists, hospitals, therapy, etc. Okay, and this is really good because for the most part, this is a skilled, licensed physician who went to medical school, at least they're supposed to, right? And they can examine the patient, they can evaluate the patient, right? Remember evaluation and management codes? Okay, they can do that and then determine what should be done next. Maybe I, as the primary care physician, can fix you, can fix that, whatever it is. Great, like a one and done, right? Okay. But maybe a specialist is needed, and then I'm going to refer you to the specialist also in the network, or, admit you into the hospital also in the network. Okay. But that is, and this basically is also based on money because a primary care physician is paid less per hour or however you want to measure it than a specialist who has additional credentials. Okay. So therefore, if you have a mole on your knee, okay, and the primary care physician says, okay, we're going to remove that mole. I can do this. I have the skills. Then that's going to cost less to remove that mole than if the patient went to a dermatologist specialist to remove that mole. Okay. Makes sense. Very logical. It's like having a friend and saying, what do you think about this? You think I need to go to the doctor? Okay. So therefore, this keeps a control on probably unnecessary expenses. Okay. Then we have a PPO, which is basically the insurance company saying, patient, if you stay in the network, we'll pay. If you go out of the network, we'll still pay, but we're going to pay less. Okay. Now, this is very beneficial to a patient who already has a diagnosis. Okay. So, for example, you have a patient who has a rash on their arm. Well, I already know that I have allergies. So instead of going to my PCP under an HMO and saying, it's my allergies, can you refer me to an allergist? Now if I'm covered under a PPO, I can go right to the allergist. It saves me time. It saves me effort. And if I already know this allergist, that's even better if they're in the network. Okay. So this gives patients a little bit more freedom to determine what they need and go where they feel like they need. And because if we go right directly to a specialist without going through the primary care physician, it's going to cost the third party payer more. So that is why premiums are higher for a PPO, because we already know there's a probability that you're going to cost me more as one of my subscribers. Does that make sense? Good. Okay. Point of service plans combines an HMO with a PPO. And, I have to tell you, I have found difficulty in finding a POS as opposed to an HMO or a PPO when shopping for health insurance. But it's, again, you may have a patient who is a patient of your facility, and this is how they are going to be paid. Okay. All right. Centers for Medicare and Medicaid Services, abbreviation CMS, 1M. They didn't invite me to the meeting. I don't know. I don't know why they couldn't have put the second M in there. It's the federal government. What do you want? Okay. Now, here we have the Department of Health and Human Services, which has two H's, and that's because they since created the Department of Homeland Security, which is now DHS, 1H. So Health and Human Services has two H's, and they are the agency of the federal government that oversees Medicare and Medicaid programs. It's not insurance. Because for Medicare, you already know you are paying into this. Yeah, just check your pay stub. They take money out of every paycheck to go into the Medicare pot so that you're covered when you reach 65. Okay. The way you tell the difference is Medicare has an RE at the end, and you can think of it for retired, versus Medicaid, which is health care support for indigent or low income individuals. Okay. And if you know people, by the way, for the working poor, particularly, the marketplace has policies with really low monthly. I saw yesterday, one woman had a policy through the marketplace, only $16 a month premium. Okay. So this is especially for the working poor, as opposed to going on Medicaid, which sometimes people feel that it is, I may not have money, but I don't want anybody thinking of me as poor. You know what I'm saying? Okay. The point is that there are multiple avenues for everyone, regardless of how much money they have in the bank or how much money they bring in each week, to get healthcare coverage. And that is really, really important. Okay. All right. TriCare. This is the military. Okay. This covers active duty service members, VA. Okay. And also retirees from the military and their families, and as well as dependents of deceased active duty members. All right. Now, one thing I want you to keep in mind is that there are VA hospitals all over the country, and they hire certified coders. So especially if you have a military background or you are a family of a military service member, this might be a great avenue. From what I have several alumni of my former students who have gone to work for the VA, and they love it. Okay, so this is a great possible opportunity for you. Now, TriCare doesn't work with reimbursement the same way that even Medicare or Medicaid works, but things still have to be coded because we need to do the research. It's all there, okay? Part of your training. But I'm just saying that you could think about it as a possible career avenue because it's good. Okay, that's what I've heard. Okay. Other types of health insurance, other types of third-party payers who you may need to send a claim form to: workers' compensation, disability compensation, liability insurance, and automobile insurance. You have to understand these things. You have to be able to look at the patients, at the documentation, and determine to whom do you send this claim? Because it's not automatically the individual's healthcare insurance. They still may have a card in their wallet. They may have health insurance, but if they were in a car accident, you may need to send this claim to the automobile insurance company, not the health insurance company. And liability insurance, let's say somebody's at the mall doing their Christmas shopping, really, before Thanksgiving even. Yes, it's possible. But if they fall down the escalator, it's not going to be the person's health insurance. It's going to be the liability insurance for the owners of the mall. Okay? So you have to look at the documentation. You have to look, especially when there's an injury, and you have to look at the external cause codes. That's why we do that, so that you can decipher and evidence who's supposed to pay for this. And it's not always the health insurance company. Okay. And remember, even workers' compensation can be a disease, like with asbestos in a factory. Lung disease could be a workers' comp claim. It's your job. This is part of your job, whether you like it or not. Duh. Okay, so follow the money. Read chapters 7 and 8. Don't forget to supplement with chapter 39 in your Let's Code It book. Okay. All right. 7 and 8 in your CIC. I know my picture is outdated. I greatly apologize for that, but such is life. Okay. I think you're all smart enough to read the words 2022. Okay. You got to be updated. It's got to be a 2022 book. Otherwise, you're studying for last year's exam, and that's going to help you not pass. Okay. All right. Take your quiz. And seriously, take the quiz. Yes, you have to use your coding books, but do not use Let's Code It. Do not use your CIC book. No, do it as if you were taking the actual certification exam. Okay? Focus and work through it. And then once you do that, do the analysis. Analysis means you're going to do a comparison, contrast and compare a wrong answer that you put with the right answer and evaluate, why is that correct and not this? And let me tell you something. A couple of students already this term have analyzed and asked that question, and guess what? They were right. The answer key was wrong. I had to go fix the answer key. Are you kidding me? See, that's the way it's supposed to work, because we are all human beings. And whoever wrote the quiz and put the answers, maybe something changed since then, or maybe I don't know. Okay. See, now I talked about the allergist. Now my arm is itching. Okay. The additional stuff, and like I said, pull out Let's Code It and look through chapter 39, which happens to be, I know this is it's called reimbursement. That'll clue you in. And any questions, any questions. If you have a question, if you're doing your analysis and you don't understand why is this right and why was I wrong, you can put it in your analysis, or you can email me. Or if you want to go through it more, email me. I'm here every day, 7 days a week, just to help you. This is what I live for. Okay, there's my email address. Next week, no session because it's Thanksgiving, my absolutely favorite holiday. All we do is cook and eat. How could it get any better? Okay, I'll see you the week after Thanksgiving. Have a wonderful